Well, good day and welcome everyone to the Canadian Cochrane Network and Centre's Research Webinar Series. My name is Adrienne Stevens. I'm the Centre's Education Coordinator, and I'm pleased that all of you are able to join us today for this, our first session of the series. And I hope you're having a great day. I just wanted to take this opportunity to acknowledge the funders of the Canadian Cochrane Network and Centre, those being the Canadian Institute of Health Research and 6 of the research institutes as part of CIHR. Thank you for your ongoing support of the Canadian Cochrane Network and Centre, as well as to the Canadian Agency for Drugs and Technologies in Health for your initial phase contribution to this funding period of the Centre. Thank you. And in fact, I think we have a few people joining us today from CIHR, so a special welcome to you. In addition, these webinars would not be possible if it wasn't for the generous support of the Research Promotion and Development Division of the Pan American Health Organization, that being the regional office of the WHO for the Americas. The Centre is grateful to PAHO for this provision. PAHO is a valued partner of the Canadian Cochrane Network and Centre. So just briefly overview the format of the webinar today. We use the voice over IP through the internet, and we are going to operate as a one audio activated at a time. If you wish to ask a question, you can raise your hand using the icon below the participants window. And for today's session, we are going to hold questions until the end, and Dr. Grimshaw will instruct you when it's time for questions. So I do remind you that when you activate your audio, just wait a moment, ask your question, and don't forget to release your audio at the end so Dr. Grimshaw can answer your question. And just to briefly review some of the features of Illuminate, so as you see the participants window here, depending on the session, the speaker may be conducting a poll, and I refer you to the whiteboard, and you can see in reference to your menu at the top, you could have a yes-no question, you could have a choice of 3, 4, or 5 answers, and that's where you would indicate your response. Do note that the way that I've set the settings for Illuminate, that the participant pool will not see your answers, only you will see what you've depressed, and I will publish the results to the whiteboard once everyone's had a chance to cast their vote. You can use your emoticons as shown at the bottom of the window if you want to send us a smiley face, or if you want to initiate applause. You can raise your hand when it's time for questions. And as well, just to bring you again to the whiteboard, as you can see, I've put in a diagram of the tools that are available on the whiteboard, and I've indicated the laser pointer is something you may be using in a session. And so let's try that now. Why not? I am curious, where are you joining us from today? So please click on your laser pointer and then click somewhere on the screen so we can see where you are joining us from. I'll just give folks a minute to do that. Okay, yes, we have folks from Canada, from the U.S., and international as well. I believe we have some individuals from, we have China. I'm just waiting for some others to come on the board. Yes, lots of places through Canada and the U.S. That's great. I'll give you another moment to put them on the board. Wonderful. Well, thank you very much for joining us. We're glad that you were able to. Just a few things to go over before we start. Yes, it is the countdown to the colloquium in Singapore, just 2 weeks away for the 17th annual Cochrane Colloquium. And for those of you who are able to attend and have not yet met me, I would love to meet you. I will be at the Meet the Entities on Sunday, October 11th, so do drop by and introduce yourself. For those of you who aren't able to attend the colloquium, I'm pleased to let you know that the Cochrane IMS team will be recording plenaries and select workshops, so do feel free to consult Cochrane.org during this colloquium and thereafter for what they are able to post. Thank you to the Cochrane IMS team. And of course, it's exciting times here in Canada with the free access to the Cochrane Library at the cochranelibrary.com. It is up to us to spread the word and to ensure others are using it. How will they know if we don't tell them? And as well, we have also launched a survey at tiny.cc/Cochrane survey. For those of you in Canada, we would like to know how the Cochrane Library has helped you. So please help us to work on extending the access beyond December by completing this survey. Well, I am eager to hear from today's speaker, so let me introduce Dr. Jeremy Grimshaw. Among his many accomplishments and projects and ongoing initiatives, he is the overseer and provides leadership to us at the Cochrane Centre here as our director. He is also the coordinating editor of the Cochrane Effective Practice and Organization of Care Review Group, and as well recently led the Cochrane Strategic Review Team, looking at the past 15 years of Cochrane in terms of governance, structure, and processes, and where the collaboration should be going in the next 10. So please join me in welcoming Dr. Jeremy Grimshaw.
Good afternoon to people in the east side of Canada. This is Jeremy Grimshaw from the Canadian Cochrane Centre. I'm delighted to welcome you to our first ever webinar, and we would be very keen to get a sense of how you or what your experience of this is, and whether the ways we can improve the process, and also topics for future webinar presentations. So what I want to do today is provide some background around what knowledge translation is, then talk about what is the appropriate unit of knowledge for knowledge translation, talk briefly about the Cochrane Collaboration, and then talk about an increasing emphasis on developing knowledge in knowledge tools for knowledge translation before recapping. I'm aware that on the call we have a lot of people who've been involved in Cochrane for some time, so this is not going to be new for everybody, but I hope that nobody will be have seen everything we're going to talk about today. So just want to give some background on knowledge translation. In Canada, it's become very important and increasingly recognized, particularly as it's part of the mandate of the Canadian Institutes for Health Research. And they define knowledge translation as a dynamic, initiative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge. And what I want to highlight here is that in particular, this definition recognizes the importance of synthesis as a key step in knowledge translation. Why are healthcare systems around the world concerned with knowledge translation? The major issue is that healthcare systems and healthcare professionals struggle to provide the quality of care that they would like to, and often fail to translate research findings into clinical practice. So repeated studies globally show that 30 to 40% of patients do not get treatments of proven effectiveness, and 20 to 25% of patients get care that is not needed or is potentially harmful. And this has been replicated across many healthcare systems and for many different healthcare problems, and I think it highlights that actually providing high quality healthcare that's based on evidence is a challenging issue for healthcare systems, and we need to find ways in which we can support healthcare systems to do this better. So if I want to move on to talk about what is the knowledge base for knowledge translation, one of the things that I often challenge colleagues about is what is the K for KT. And in the first half of the talk, I want to highlight three potential sources of evidence: primary studies, narrative reviews, systematic reviews, and meta-analyses. And what I will hopefully persuade you is that individual studies and traditional narrative reviews do not provide a sound or robust evidence base if we want to think about what knowledge should be transferred to improve quality and practice. So if we talk about primary studies, one of the problems that healthcare systems and healthcare professionals face is just the sheer volume of information produced each year. There are over 20,000 health journals published every year. Within those journals, the published research is of variable quality and relevance. And that research users, whether they're consumers, healthcare professionals, policymakers, or researchers, have often been poorly trained in critical appraisal skills. Further, most professionals have less than 1 hour a week to try and keep up to date with the research evidence. So we are asking healthcare professionals to do an impossible task if we want them to try and keep up to date with primary studies to make sure that their practice is based on the best evidence. And if that's difficult for healthcare professionals, think how much harder that is for consumers, policymakers, managers who may have less training in relation to evidence-based care than many healthcare professionals. In addition, I would argue that individual studies rarely by themselves provide sufficient evidence for policy or practice changes, and individual studies can often be misleading. And I want to highlight the work of John Ioannidis. John is a Greek epidemiologist who's done a landmark series of studies looking at how evidence evolves in healthcare. And the study I want to talk about today wanted to, or asked the question, is there any primary studies that are that we can identify that we should automatically trust? And what John did in this paper was to identify all the studies that have been published in major medical journals between 1990 and 2003 that were cited more than 1,000 times. Now, for those people on the call, it's rather humbling as a researcher to recognize that the average number of cites that any individual article gets is between 0 and 1. So studies published in major medical journals that have been cited over 1,000 times are the very fine tip of the iceberg. And John's question is whether these studies are sufficiently robust that we should have confidence in them by ourselves. So he identified 115 articles being published between 1990 and 2003. 49 of those were looking at evaluations of healthcare interventions, and 45 out of the 49 claimed that these interventions were effective. So the primary studies reported in these medical journals with more than 1,000 sites thought that the intervention that was tested was more likely to do good than harm. But what John then did is track forward these studies and say, well, were there any additional studies focusing on exactly the same clinical areas published? And if there were, did they confirm or contradict the original findings of these key articles? And by 2004, he found that 5 of 6 non-randomized studies and 9 of 39 randomized studies were already contradicted. So further studies argued that, or found that the interventions were not effective, or were found to be exaggerated, so that the results published in other journals and other studies were less positive than those in these major medical journals. And John concluded that even these very high-profile key papers that are published in these medical journals cannot be trusted by themselves. We need to look at the global evidence base to start to understand the benefits and harms of different treatment options. We see the same study in epidemiological and basic science studies. This paper is another paper by John Ioannidis, and here he was looking at the evidence and how it evolves in studies looking at gene-disease association. And what he's highlighting here is that often in gene disease association studies, the first studies that are published seem to show very, very strong relationships or associations between the gene and the disease of interest. So if we look at the, just hold on a second. Ooh. If we look at the green line here, which is tracking the evidence as it accumulates for Down dementia and APOE gene. What this line shows us is the first study was published with about 45 patients included in total of it, and that suggested a very large odds ratio of 0.03, which would be a very striking association if it was in fact borne out by subsequent studies. But what John then has done is said, well, by the time the second study study was published, and this study added about another 150 patients, so we had around 200 patients. Already the cumulative odds ratio was much reduced, and as further evidence accumulated, we found that the likely association was much weaker than the original study suggested. So again, even in sort of more basic science or epidemiological studies, individual studies, particularly if they're the first study in a particular field, need to be replicated before we have any confidence about whether they likely represent the truth or may be misleading due to either bias or chance. So the key arguments here are that the results of individual studies need to be interpreted alongside the totality of evidence, in other words, systematic reviews. And I would argue that the emphasis on individual studies may distract the stakeholder group, increasing the noise to signal. And I think that as potential users of reviews, we need to make sure that we don't believe the hype. And as potential research producers, we need to try and make sure we don't generate the hype and try and put out key messages based on individual studies, as opposed to saying, what does the body of evidence tell us about what we know to be true in this field. So if primary studies aren't a good unit of knowledge for knowledge translation, what about the traditional narrative reviews? These are the reviews that have been in medical journals for hundreds of years, where the great expert basically provides guidance or his or her views about how certain treatments should be used or diseases be managed. Cindy Monroe, who's an epidemiologist from San Antonio, did some work in the 80s where she basically pointed out that when we look at these traditional narrative reviews, the authors are asking us to trust them. They very rarely tell us about what evidence they looked for, how they assessed whether that evidence was robust, and what attempts they went to look at the global evidence. And she argued that these reviews could be criticized for their failure to apply scientific principles to the review process, leading to the criticism that such reviews are often haphazard, biased, and subject to the idiosyncratic impressions of the individual review author. So if you have a traditional review in a medical journal that doesn't, for example, have a methods section, you have no idea whether that review author has done a really good job and gone out to try and identify all the research evidence in the world, appraise that evidence, make sense of it, and then provide very carefully thought through recommendations, or have they gone to the last 3 papers that they found, or the last 3 papers that support their own views, and largely summarize those. So again, I would argue that narrative reviews are not a good knowledge basis for knowledge translation. And that leads us on to knowledge syntheses or systematic reviews. So knowledge syntheses, in contrast to these narrative reviews, use rigorous scientific methods to identify, assess, and synthesize the worldwide available evidence. And there are a broad range of methodological approaches, and there's a lot of evolution in the methods at this point in time. What I'm going to focus on particularly today are systematic reviews and meta-analyses, but I'd like to highlight that certainly the methodological development in this field at the moment is very rapid, and there are a broad range of methods for synthesizing different types of evidence and synthesizing evidence for different types of questions. And in particular, I'll just highlight that I think one growth area is syntheses of qualitative methods that have been developed and are being further refined. You might find a broad range of terms being used to describe these methods. And I think over time what we'll probably find is that we'll have a much better sense about the key principles of syntheses of qualitative studies, and we'll probably have a much more reduced set of key principles and methods that we apply. But I want to move on to a large detailed focus on systematic reviews. So these are reviews of a clearly focused question that use explicit methods to identify, select, and critically appraise relevant research, and also to collect and analyze data from the studies that are included in the review. Cindy Rowe again argued that they're an efficient scientific approach to identify and summarize evidence on the effectiveness of interventions, that because they bring together the global evidence base, allow the generalizability and consistency of research findings to be assessed and data inconsistencies to be explored. Systematic reviews involve stating the objectives of the research, defining eligibility criteria for studies to be included, identifying all potentially eligible studies, assembling the complete data set, analyzing the data set, and then writing it up. And the reason I like this description of the process is I think this is a generic description of a scientific method that we can apply to any type of research question. So within an individual, say, randomized controlled trial of a drug, our objectives might be to estimate the benefits and harms of that drug. Likewise, within a systematic review, we might want to estimate the benefits and harms of a drug across multiple studies. Defining the eligible criteria, those would be in a primary study, looking at which patients we want to include. Within a systematic review, which are the studies that are going to give us the most robust evidence to answer our question. Then going out and recruiting patients for your trial, or doing very careful searches to identify all the potential eligibility studies, work out which reviews actually or which studies meet your eligibility criteria before starting to do data abstraction and analysis. So for me, this way of describing systematic reviews just highlights that all we're doing is applying rigorous scientific method to the process of doing reviewing the clinical literature. And instead of our units being individual subjects, our units are individual papers, but we still are using the best scientific approaches available. And systematic reviews in healthcare were traditionally used for particularly questions of effectiveness, for assessing the benefits and harms of treatment. But I think you can use this as a generic method that can be applied to any questions. So we now have systematic reviews of observational data, looking at the etiology of disease or prognosis of disease, reviews of diagnostic test performance, reviews of the efficiency of interventions and economic evaluations, but also reviews of research methods and of theories and models. So we can, once you start to think about how to review any area of the literature in the world, I think you can again apply rigorous scientific methods to ensure that you do the best job you can and that you are minimizing the likelihood you get misled during the process of doing the review. Meta-analyses are basically a subset of systematic reviews that employ statistical methods to combine and summarize results of several studies. Sometimes systematic review and meta-analysis are the same thing. However, what we find is that systematic reviews are the sort of broader term, and then meta-analyses focus upon those systematic reviews that particularly employ statistical methods to combine and summarize results of these studies. And this is an example of a systematic review and meta-analysis looking particularly at clinical science. And I'm going to ask the audience whether you can give me a show of hands, and I need Adrian to help me work out how to do this. How many of you would feel confident about basically interpreting this meta-analysis and describing it to a colleague? So, Adrian, can we set up are you just doing that? Adrian's just setting this up. So in a second, we'll ask you to basically vote on whether you feel that you could interpret this meta-analysis, and also whether you could describe the results to and the forest plot to a colleague. Okay. And can we tell when people have done it? Okay, keep going. We can see when you're clicking in to sort of say that you've joined. Okay, we're being a little bit sort of quiet and working through. Okay, Adrian's just going to write me a note. Okay, there's a bit of delay for a few of you. Should we just go? Okay. So about a third of you think that you could describe this to your colleagues. About half of you haven't responded, and about 12% say you wouldn't feel that confident about how to actually do this. So what I think I might do is just very quickly walk you through what this meta-analysis and forest plot is showing. So this is actually a very classical meta-analysis that was done within the Cochrane Collaboration, looking at whether steroids provided to women who are potentially going to preterm labor might help accelerate the lung maturation of babies and reduce the likelihood that they actually have a respiratory distress syndrome, which is a problem where babies can't breathe through their lungs very well, or in this particular meta-analysis, whether it actually saves or reduces fetal and neonatal deaths. So what we have is down here, or the listing down here, is every individual study that the review authors found, and there are 13 studies that were found, and each are listed by the author's name, and it also gives you the year about when they were published. The next column, which is the treatment column, gives you two numbers. The larger end tells you how many patients were randomized. So in this first study, 110 women were randomized to receive the treatment, the antenatal corticosteroids. And the little end tells us how many of their babies died either as a fetal death or neonatal death. So 24 out of the 110 mothers, or 24 babies from the 110 mothers who were randomized suffered from a fetal and neonatal death. In the control arm, 108 women were randomized to receive corticosteroids, and 36 babies suffered a fetal and neonatal death. The next line here is a graphical representation of this individual trial result. The big point in the big blue blob gives us the summary effect, and this summary effect would suggest that it does look as though there is a reduction in the number of deaths following antenatal corticosteroids. Anything on to the left hand of this line suggests that the intervention seemed to reduce deaths. Any results that on the right hand side suggest that the intervention increased death. But you'll also notice that there are lines flowing out from the point estimate, and these are the confidence intervals, which tells us basically how much precision we have around that estimate. And if the confidence intervals cross over this line, it will suggest that the individual study was not statistically significant. So if we take this study, although it appeared to show a reduction in the number of neonatal and fetal deaths, the confidence interval still crosses the no effect line, and so this individual study was not statistically significant. And you then get the risk ratio for each of these individual studies. If you look down this group of studies, you can see that for the vast majority of them, the point estimate was on the left-hand side of the no effect line, suggesting the intervention seemed to lead to reductions in fetal deaths. But there are only two studies, I think, that actually where the confidence intervals don't cross over the no effect line. So only 2 out of 13 studies by themselves demonstrated statistically significant results. At the bottom, you have a pooled estimate, and the pooled estimate says, well, what would happen if we if we recognized we'd actually randomized close to 3,500 women, and we pooled data from across all of these studies? Would it look as though the intervention was beneficial? The intervention was harmful, or we still couldn't tell because the results were not statistically significant. So the black diamond at the bottom gives you an idea about the pooled result. And what you can see here is that the black diamond and the confidence intervals are now incorporated from the black diamond shows that or does not cross over the no effect line, and so it shows very clearly that antenatal corticosteroids appear to reduce the likelihood of fetal and neonatal death, and you can see that the risk ratio is about 0.77 as a result of that. I hope that very quick tour around a forest plot is helpful for people. One of the things that you may want to do when you look at this is, first of all, or when you look at a forest plot, is first of all look to see whether there is consistency of effects across either side of the no effect line. What we are particularly focusing on the larger studies, and these in Cochrane have got the larger squares, and then look at the diamond at the bottom, and look to see whether that suggests that there are statistically significant differences as a result of the treatment. So as I said, this was a landmark study that was done initially in the late 80s, early 90s, and demonstrated for the first time that corticosteroids reduced respiratory distress syndrome and reduced fetal and neonatal deaths. And this led to major changes in the way that obstetrics is practiced globally. We can apply the same issues to preclinical science. And so this is an interesting story about a large randomized controlled trial called the ENABLE trial that randomized over 16,000 patients to receive an endothelin antagonist Bosentan for the management of heart failure. And I think when the trial was started, there was a very strong expectation that this intervention would be found to be beneficial. However, what was actually observed in the clinical trial is that, in fact, there's no benefits from use of this agent, and there appeared to be an increase in the early deaths as a result of that, or as a result of the treatment of the agent. Whoops. And this was very puzzling to people in the cardiovascular community, and so because the animal models were interpreted as being very positive and suggested that this should be a treatment that would really benefit human beings. And so a group of I think all Canadian sort of authors went back to do a systematic review and meta-analysis of the animal models of endothelin receptor blockade on the survival of the animals in experimental heart failure. And what they wanted to see is whether basically the interpretation of these animal models had been incorrect because there hadn't been a formal systematic review, or whether this was a finding where the animal model did appear to be beneficial, but once we moved into humans, there's no benefit. And so they did a systematic review and meta-analysis. And so you can see that in total there were about almost 1,000 animals that were randomized to receive endothelin blockade or control. And when you looked at mortality as the outcome, you can also see that really all of the point estimates are scattered around the no effect line, and then the pooled estimate suggests that there really was no obvious benefit on survival as a result of endothelin blockade in these animal models. So the authors of this argued that in fact, basically the ENABLE trial should not have been conducted. That if the trialists had conducted a good systematic review of the endothelin receptor blockade before they planned the original clinical trial, they would probably have not thought it was worthwhile to actually conduct that and randomize half the patients to an ineffective but potentially harmful agent. And they argued that increasingly we should be using the methods of systematic review and meta-analysis for looking at both preclinical science, and particularly at the time when we're thinking about translating research from animal models into human models. So I would argue that systematic reviews are one of the building blocks for knowledge translation activities. They also help us because they can highlight some of the problems and methods of reporting current studies. They can help us prioritize future research. They outline what is currently known on a topic to form the foundation of proposals for further research. And they also build capacity through teaching critical appraisal skills. My best research teaching has been when I've been doing systematic reviews and looking critically what other trialists have done. So I would argue that systematic reviews and knowledge syntheses should be the basic knowledge unit if we're thinking about knowledge translation. So I'm going to move on now to talk a little bit about the Cochrane Collaboration. I think most people on the call will know a little bit about us, but just to highlight the work that we do. Cochrane is an international organization that aims to help people make well-informed decisions about healthcare by preparing, maintaining, and promoting the accessibility of systematic reviews on the effects of healthcare interventions. So I've actually sort of italicized 4 areas of this mission statement. The first is that Cochrane believes we're there to help people make well-informed decisions, and by people we think our potential users of Cochrane are consumers, healthcare professionals, managers, policymakers, and other researchers. And we believe that if people are informed by the current best evidence about benefits and harms of different treatment options, they can make well-informed decisions. Cochrane also is committed to maintaining systematic reviews. Many groups are doing systematic reviews at the moment, but very few are trying to keep them up to date. And in Cochrane, we try and keep our review, or make sure that we've searched for new evidence at least once every 2 years. This is a major challenge for us to do, but we do know that Cochrane reviews are more likely to be up to date than other reviews. And finally, we're interested in trying to promote the accessibility of reviews so that people around the world have full access to Cochrane. The Cochrane Collaboration was established in 1993. It's not-for-profit and is independent, so we do not accept any commercial funding, particularly around the protection of systematic reviews, because we know that that is likely to influence bias into the process. So our infrastructure is largely funded through public funding sources. In Canada, as Adrian said earlier, the Canadian Institutes for Health Research. So Cochrane is an international health research community. There are more than 24,000 active contributors, and most people are contributing in a voluntary way. And this includes over 16,000 review authors. We have over 1,000 review authors in Canada alone. These contributors come from more than 100 nations, and we basically organize ourselves into different types of groups to actually do the workload. Within Canada, the Canadian Cochrane Centre acts as a global sort of access point for Cochrane. We provide support to review authors in Canada through training, to users of Cochrane by doing knowledge translation activities, and also to the different groups in Canada who are engaged in doing the work of Cochrane. We have 6 review groups in Canada, and these are the editorial basis for international groups that focus upon supporting reviews for specific clinical areas. We have the BAC group at the Institute of Work Health in Toronto with Claire Bombardier, the Effective Practice and Organization of Care group with myself in Ottawa, the Hypertension group at UBC with Jim Wright, the Inflammatory Bowel Disease and Functional Bowel Disorders group at University of Western, musculoskeletal, with Brian Fagan, the Musculoskeletal group at University of Ottawa with Peter Tugwell, and the Upper GI and Pancreatic Disorders at McMaster University with Paul Moyedi. In addition, we have 14 Canadian editors for review groups where the editorial base is outside of Canada, but these are people who are playing a major role in ensuring that reviews get conducted in those areas. We have one field in Canada which tries to ensure that cross-cutting interests are represented in Cochrane. So rather than having a review group for asthma in children, we have a review group looking at asthma in general, but then the child health field tries to make sure that pediatricians interested in child health and asthma will participate in those different review groups. And we'll also try to do knowledge translation specifically to consumer groups and professional groups and policymakers interested in child health. And we also have 3 methods group based in Canada that are always trying to improve the methods of Cochrane. And in addition, we have other contributors to the methods to other methods groups. So Cochrane is a very major contributor to this global effort. We produce between sort of about 10% of all the reviews in Cochrane, and really sort of are a major presence in terms of making sure that we're contributing to this global good. We publish our reviews in the Cochrane Library, and we would argue the Cochrane Library is the single most reliable source for evidence on the effects of healthcare interventions. So in issue 3 of 2009, there were around about 4,000 reviews completed by Cochrane review authors. And we have information about another 2,000 reviews that are ongoing. In addition to Cochrane reviews, there are also structured abstracts produced by the NHS Centre for Reviews and Dissemination in the UK of over 10,000 non-Cochrane reviews. We have information on close to 600,000 clinical trials, information about 12,000 methodological studies. We work with the International Association of Health Technology Assessment Agencies to provide access to their reports, and we also have a database of 27,000 economic evaluations. When you search in the Cochrane Library, you search across all of these databases at the same time. And in my experience, and certainly in the last 5 to 10 years, it's very unusual for someone to search Cochrane and not find something that's relevant to their needs. Even if it's not within the Cochrane reviews themselves, it might be in the other reviews database or in the trial database or the economic evaluation database. And this is why we'd argue that Cochrane is a very powerful evidence source for people interested in information about benefits and harms of different treatments, and increasingly now diagnostic tests. In terms of the quality of Cochrane reviews, David Miller identified 300 systematic reviews that were published in November 2004 and included in Medline. And this coincided with a Cochrane update so that there were 125 Cochrane reviews. This would suggest that Cochrane is probably doing about 20% of all reviews published annually, and it's worthwhile noting the majority of non-Cochrane reviews get published in the specialty journals. And compared to non-Cochrane reviews, Cochrane reviews were more likely to have a number of characteristics that we think are more likely related to the quality of the review. So the first would be reporting using a protocol, reported being an update of a previous review, did not include any language restrictions. Cochrane reviews searched twice as many bibliographic databases. They were twice as likely to assess the quality of included studies, twice as likely to assess likely publication bias, although that's clearly an area where Cochrane can still do much better, and were much more likely to report funding sources. And so we would argue from this study, but also from other studies, that compared to many other non-Cochrane reviews, Cochrane reviews in general are of higher quality. In terms of Canadian access to the Cochrane Library, in some ways this has been a bit of an embarrassing study. Around about 50% of the world's population has free access to the Cochrane Library at the point of access. If you are in India, you have free access to the Cochrane Library. If you are in the UK, Australia, if you're in Spain, you have free access to Cochrane Library. And until recently, we've not had free access to Cochrane in Canada. At the moment, we have a national license pilot going on, which will run out at the end of this calendar year. But at this point in time, any citizen in Canada can go to the www.thecochranelibrary.com and access the Cochrane Library free of charge. And what we're hoping to demonstrate is that there is an increase in the number of Canadians who access Cochrane and make use of it, which is why the information that Adrian was asking about at the beginning of the webinar around tell us your Cochrane stories, go and look at the Cochrane Library, see, play with it, search it, give us feedback about how we can improve it, will all be helpful when we then go back to our funders and sort of need to think about increasing it or trying to get this on a permanent basis. So, what I've talked about so far is what knowledge translation is, highlighted the limits of primary studies and narrative reviews as sources of knowledge for knowledge translation, argued that we should look at systematic reviews and meta-analyses as a knowledge unit for knowledge translation, highlighted Cochrane as a major resource for systematic reviews, and what I want to do in the next last few minutes is just talk about how once you've got things like Cochrane reviews, they can be the building blocks for other knowledge tools. And I'm largely going to focus on what I call knowledge resources, but it's worthwhile noting that all health technology assessment agencies and most guideline developers and patient decision aid developers use systematic reviews as part of the evidence base for their own products. But what I want to talk about in the next few minutes is particularly how the availability of existing systematic reviews can be used to provide a knowledge resource for diverse stakeholders. And what I want to do is highlight in particular the work of John Lavis, who is the policy liaison lead for the Canadian Cochrane Centre Network and holds a Canada Research Chair in Health Knowledge Transfer and Uptake, and is particularly focusing upon knowledge translation targeting high-level decision makers and managers. One of the things that John has done in collaboration with the Canadian Cochrane Network and Centre is develop a database which is an online repository for management and policy relevant evidence related to governance, financial and delivery arrangements within healthcare systems. So when John talked to policymakers about the barriers for them to use evidence, they highlighted three broad barriers. One is that they didn't believe there's any evidence out there that's relevant to them. The second is they didn't know how to access the evidence, and the third is they didn't have time to actually to read through systematic reviews and try and make sense of them to understand what the bottom line was for them. And so John has basically developed this database, this repository, as a way of bringing together all the available systematic reviews and trying to address those issues head-on for policymakers. So this slide now is probably out of date. I think the database has been updated since I last used this slide. But the database now contains citations for more than 800 systematic reviews, overviews of systematic reviews, or policy briefs. About 500 of those relate to the benefits and harms of different treatment options or different policy options. And there are over 200 Cochrane reviews and 100 ongoing Cochrane reviews at this point in time that specifically address high-level management and policy decisions. So this addresses John's first challenge from policymakers. We don't believe there are any systematic reviews out there relevant to us. There are more than 800 reviews relevant directly to very high-level decision-making in healthcare systems. And Cochrane produces about half of the reviews of the benefits and harms of different treatment options. So if you want to go to the PPD database, you have to go to John's website, the Program and Policy Decision Making, and the URL was above this, and then you click on this area, and then down to Systematic Reviews of Management and Policy Making. That takes you through to this screen, and you can either search by using a keyword taxonomy, the type of review, or citation details. So there's different ways that you can access the information. Okay, I've missed a slide. But if you search on, if you search in the taxonomy, that will give you a series of headings that you can look at. And when you look at those headings, you can then click on those and get a list of all reviews relevant to that area. So these were reviews identified in, or reviews identifying about who actually provides care. And you can see there's one review that John's highlighted here. And from this list, if you click on the More button, you get to a one-pager that tells you what the bibliographic details are. So this is a Cochrane review that's available from the Cochrane database of systematic reviews and reviews. And in Canada at the moment, you can go to the to PubMed to look at the bibliographic details. You can access the Cochrane library free of charge at this point in time. But you can also identify that there are user-friendly summaries being produced by 3 different groups. And if you click on this area, you can actually get to not only the Cochrane Library, the Cochrane Review, but also a friendly front end that has been developed by the Australasian Cochrane Centre for their policy liaison initiative. And so again, this is trying to help policymakers rapidly access reviews, and then wherever possible, if we can identify pre-digested or summaries of reviews, to make those available to decision makers. So once we have things like Cochrane reviews and other systematic reviews, we can start to make them much more easily accessible to decision makers globally in a way that will be hopefully or make it easy for them to seek evidence. We've got similar examples of knowledge resources for managers. So this is a project that the Cochrane Effective Practice and Organisation of Care group is doing with the Canadian Agency for Drugs and Technology and Health, where we have identified and summarized over 190 systematic reviews of how you change clinician behavior. if we're interested in trying to improve the quality of care or trying to, say, improve prescribing, then changing physician behavior or nursing behavior or pharmacy behavior is often a key step within that process. And so again, this is trying to make the systematic reviews available to decision makers and managers who are grappling with how to improve the quality of care for diabetes management, for use of specific lab tests, or for prescribing in relation to their day-to-day work life. So again, if we have the systematic reviews available and then you have groups that can bring them together and appraise them, it really helps managers to make sense of the information rather than expecting them to go out and find the evidence and appraise it. The last example I've got is looking at knowledge resources for patients, and this is an initiative between the Arthritis Society and the Cochrane Musculoskeletal Group. If you actually look in or on their website, you'll find that there are Cochrane reviews of arthritis treatment, and if you clicked on the arthritis button down here, you'd get to another screen where there's a list of all the Cochrane reviews relevant to arthritis, and if you then click on the Tylenol, you'd actually get to a lay summary that's been written in language for normal consumers, and this is also available in French in the Canadian Arthritis Society. Again, by having systematic reviews available, they can be the knowledge engine for other knowledge packages to come along and make them accessible to specific user groups in a way that extends Cochrane's reach into many, many different ways. So, just to recap, healthcare systems globally fail to translate research evidence into policy and practice. Knowledge translation needs to be based on robust evidence. Knowledge syntheses, including systematic reviews, are the basic building blocks for knowledge translation. The Cochrane Collaboration is an international not-for-profit organization that is currently responsible for producing 20% of systematic reviews globally. Cochrane reviews are of higher quality than non-Cochrane reviews. Canadians currently have access to the Cochrane Library through a pilot national license. Please make sure you go and have a look at it and use it, because if you don't, then we may actually lose this national license. But also, I think as important is the availability of these high-quality systematic reviews like Cochrane can allow other knowledge packages to develop other knowledge tools and resources to support knowledge translation, and there are many other examples that I could have used of that. So those are just the details of how to contact me and other folks in the Canadian Cochrane Centre. If there's anything you want to follow up from today, then please email one of us, and I will get back to you. So I think we've probably got another 5 minutes. Adrian was getting very worried about whether I was going to finish on time, and I probably went slightly longer than anticipated. But if anyone's got any questions now, I'd be very happy to answer them, or try and answer them. So what we need you to do, if you've got a question, is to actually raise your hand.
Are you going to make the slides available to us?
Okay, go ahead.
I'm most interested in the references that you cited to be able to, take a look at in-depth reading materials. Thank you.
Charlie, it's Jeremy. We had a real problem hearing you at that point in time. You could either quickly type in your email into the message box, or you could ask it again. But can you try and turn up your volume? Okay, Charlie, go ahead.
Can you hear me now? Very low. I've got it at the maximum now. My point was making available the slides as well as the references. A yes/no answer would be fine, and what you're going to do though. Thanks.
Thanks, Charlie. Yes, we'll send PDFs out to anybody or to anyone who's on the call. And we're very happy for, I think this will also be archived, so also people can come back and look at this at a time in the future if they would like to. Okay, who's next? I'm just looking. Okay, so Joseph Ashong, could you ask your question now?
Hello. My question is, how wide is the Cochrane idea? Do you have centers in Africa? Okay. Thank you.
Okay, thanks for that question, Joseph. Yes, Cochrane is a global organization, so that we have review authors and people working in Cochrane across 100 nations in the world, including many active in Africa. We do have 13 Cochrane centers, and the main reference center for Africa, or for sub-Saharan Africa, is the South African Cochrane Centre that is based in the Stellenbosch University in South Africa under the leadership of Jimmy Volmink. There are members of staff there who also are Francophone and so can help with Francophones in Africa who want to access Cochrane. And also at the moment the Canadian Cochrane Centre and the Radio Francophone Cochrane can provide additional support for Francophones in Africa. For people who are working in and living and working in Northern Africa, quite often the reference centre is one of the European bases, just because the geography is easier and sometimes the language is easier. So the next question is from Michael Brown.
Yes, it's a simple question. What is the function of a knowledge broker at the Cochrane Centre?
It's certainly not a stupid question. I think we're trying to work that out as we go along, Michael. It's a term that's been brought about or that's being used commonly in Canada, and it really comes from the observation of the concern that we have two communities, a research community and a knowledge-using community, but neither is particularly good at communicating with each other. So the idea of a knowledge broker is that they will work to try and bridge the research world and the knowledge using world, and they need to be aware of, if you like, enough research knowledge to be able to talk to researchers in an informative way, but also then to be able to basically work with and engage with a broad range of knowledge users to translate, if you like, the research language to language which is more accessible to the knowledge-using perspectives. So Cheryl Aratoon, who's our knowledge broker, for example, works with many of the professional groups in Canada to try and make Cochrane reviews accessible to physios, speech and language pathologists, OTs, physicians, nurses, pharmacists, and does that by basically having one foot in the Cochrane camp and identifying reviews that are relevant to those groups, but also feeding out that information to these groups and helping them interpret that and work out what it means for clinicians in Canada. The next question is from, and this will have to be the last question I'm afraid, is from Jaya Akoli. So please ask your question now. Jaya, we can't hear you, so if you've got a mic, if you can activate your audio, or you could also type the question if you want us, if you can do that quickly. Yeah, I'm not sure what's happening, Jay. We can't actually hear you. We haven't got. Oh, I wish to know how I can start a Cochrane Centre at my school. Maybe one of the things, Jay, is you could email me outside of this, and we can have a conversation about what that actually entails. There are some very specific issues about setting up a Cochrane Centre, but certainly what we want to do is sort of try and make sure that that anybody who wants to get involved with Cochrane can, and so I'd be very happy to have that conversation with you. But maybe you could email me after this, and my email is just on the screen here, jgrimshaw@ohri.ca. We're going to have to finish the session, but we're also sending out, just so you know, the PowerPoint slides to everyone who's been on it. Thank you very much for your participation today. Please let us know from your perspective if this worked well, if it didn't work as well as you hoped, how we could improve this, and also if you've got any ideas about webinars in the future that you would like us to actually do, then please let us know, and we'll try and address those. And we look forward to seeing you on future webinars.
Thank you, Jeremy, and I echo everyone else's applause. You can join in with me again. Thank you for joining today. If you just want to stay on the line, what I will do is actually send through the evaluation form as well as the PowerPoint online through Illuminate before you sign off. Thank you and have a great day.